Hello friends. In the series of X-ray, today we will see second lecture. In this lecture, we will see how to read a normal X-ray. What are the things we should see in normal X-ray and where to see normal structure. So what are the normal structure in normal X-ray? So let's see. So we will see normal structure in the chest X-ray. So whenever you find X-ray, you have to read X-ray in four compartments. First is upper abdomen, means the the part which is below lowermost of X-ray. Second is mediastinum. So what is the mediastinum? The space between two lungs. See, this is two lungs and the space between this white structure. This is mediastinum. Okay, so mediastinum having heart, large vessels, aorta, pulmonary artery, trachea, esophagus. So this is mediastinum. Another thing is bone and soft tissues. What are the bones? Like ribs, scapula, clavicle. So these are the bones we should look for. Another thing is soft tissue. This is muscles, fat, soft tissues. So we have to see in normal X-ray. Last thing, important thing, this is lung parenchyma. Because most of the abnormalities there in lung parenchyma. We should see in last so that we should not miss other things in other part like mediastinum, diaphragm, bone. So in this lung parenchyma, we should look for alveoli and interstitium. So I'll discuss one by one. So this is normal X-ray in front of you. So as I told you, in four compartments, we should see normal X-ray. Okay. So first, let's see upper abdomen. So I told you upper abdominal part is lowermost part of X-ray. Okay. So it is having many things, but in left side, if you can see, there is fundus shadow. Fundus shadow means air in stomach. And whenever there is air, it will looks black in X-ray. Sometimes you can see other shadow, black shadow also. What is that? That is colon, large intestine. That is called splenic flexure of large colon. That will also cause cystic lesion means black spots. That is splenic flexure. Then right side below diaphragm, you can have liver. So liver, if it is having that abnormality like liver abscess or hepatomegaly, it will push diaphragm to upside. Okay. So here is liver. Then diaphragm. There are two diaphragm. Left diaphragm, right diaphragm. Okay. So which is higher up diaphragm, which is lower. So right side is higher. Left side is lower. Why right side diaphragm is higher than lower side? Because of liver. Because liver have to occupy this area, right side. That's why it pushes diaphragm to upper side. So right diaphragm is elevated as compared to left side diaphragm. Okay. Then important is costophrenic angle. So what is costophrenic angle? Phrenic means diaphragm. Have you heard phrenic nerve, which is supplying diaphragm? So phrenic means diaphragm. Costal means this ribs. Okay. So angle between this ribs and diaphragm is called costophrenic angle, CP angle. It is sharp like a needle tip. Can you see? This is sharp. This is needle tip. Okay. If it is not sharp, if angle is orbitated, it means there is collection of fluid in this angle. That is CP angle. Not only fluid. If any mass or consolidation, anything can occupy this CP angle. But majority of patients, if angle is obliterated, we should think of pleural effusion, collection of fluid in the CP angle. So this is upper abdomen. Then coming to mediastinum. So what is the meaning of mediastinum? Space between two lungs. Okay. So these are the lungs. Space between two lungs is this white area. So this is mediastinum. And mediastinum is full of blood and soft tissues, lymph node. That's why it looks white color. If it is air, it will looks black, but this is white color. So what are things there in mediastinum? We will see from upward to downwards. Okay. So if you see upward, can you see this black tube? So this is trachea, because there is air in the trachea, and whenever there is air, it will looks black in chest X-ray. So if you trace trachea carefully at the level of T4, T3, T4, it will divide. Can you see this division? So this is carina. Okay. So after carina, trachea divides into two, right bronchus, left bronchus. So this is trachea and carina. Posterior to trachea, there is esophagus, but esophagus just behind trachea and it is collapsed normally. So we cannot see normal esophagus in chest X-ray. In PA view, little we can see. Okay. So below trachea, what we can see? This is vertebra. Can you see? This is vertebra. Okay. In last class, I told you, if you are able to count vertebrae below T4, it means there is overexposed film. But here we cannot count below T4. So this is good X-ray. Okay. So in between vertebrae, there is small white colored shadow. Can you see? This is shadow. What is this? This is spinous process. As I told you, spinous process, the distance between medial end of clavicle and spinous, it should be equal on both sides. Why? Because if distance between spinous process and clavicle is more on one side, it means there is a rotation. And for ideal X-ray, there should be no rotation. So for to see rotation, we have to see spinous process and we have to see distance between middle end of clavicle and spinous process. This is how we should look for rotation. Then come downwards, there is hilum. What is hilum? Can you see this prominence? Both side. So this is hilum. So what is hilum? Hilum is the structure of lung where lung is getting blood vessels and main bronchus. So when there is tracheal division, right main bronchus goes to right lung, left main bronchus goes to left side, and there is pulmonary artery too, and pulmonary artery, right pulmonary artery, left pulmonary artery. So these pulmonary artery, bronchus, vein, and lymph node, lymphatics, they are entering in the lung by hilum. So you can see in hilar area there is prominence. So what is this? This is pulmonary artery. This is hilar, pulmonary artery. So as I told you, right side diaphragm is higher than that of left side, but hilum it is opposite. Left hilum is lower side. Right hilum is lower side, and left hilum is above side. Why? Why so? Because in left side, pulmonary artery takes a loop on the left bronchus. See? So this is carina. Okay. So pulmonary artery goes like right side like that. But in left side, pulmonary artery take loops from bronchus. So that's why left side is higher and right side is lower. Okay, so left side is higher because it takes loop. So whenever you ask question, which hilar is lower side, which has higher side, so right hilum is lower side, left hilar is above side. But diaphragm, right diaphragm is above, left diaphragm is lower side. Okay, so this is about hilum. Now see important thing, cardiac border. So in chest X-ray, can you see cardiac border? Yes. So this is cardiac border. This is cardiac border. Okay. So what are the structure makes cardiac border? That is important. Okay. So let's see from upward to lower side. So whenever you see this is arch. First, the first curvature on the left side, that is aortic arch. We know that ascending aorta comes in left side, make arch, and then descend as a descending aorta. So if you see carefully, here is shadow. Can you see? Can you see this one? So this is descending aorta. So descending aorta goes posteriorly and continue as the abdominal aorta. So this is arch of aorta or aortic arch. Okay. Then there is slight depression. Again, there is a curvature. So what is that? This is pulmonary trunk. Pulmonary trunk. Okay. So you can see this hilum mainly that is pulmonary vessels. Okay. So this is pulmonary trunk. Okay. And between aortic arch and pulmonary trunk, there is depression. That is called AP window. So whenever there is malignancy or tuberculosis, so AP window is occupied by lymph node. So we can take FNAC by endobronchial ultrasound. So this is AP window. This is pulmonary trunk. This is aortic arch. Okay. After that, there's small things, that is left arterial appendages. What is that? Left arterial appendages. Okay. And after that, there is large curve. What is that? This is left ventricle border. Left heart border made by left ventricle. So whenever there is cardiomegaly or there is congestive heart failure, left side will get dilated. So there will be cardiomegaly. This is left side, left heart border. Okay. Now come to right side. Right side, if you see clearly, this is one shadow. So this is IVC, inferior vena cava. And where inferior vena cava drains? In right atrium. So this is right arterial border. What is that? This is right arterial border. So after right arterial border, there is SVC, superior vena cava. Okay. So right mediastinal border is right superior vena cava, right arterial border, and IVC. Okay. So left side, left ventricle, left arterial appendages, either right atrium. So where is right ventricle? So right ventricle is anterior structure. So it will come here. Since this is 2D structure, so we cannot see right ventricle. But right ventricle lies on anterior side. Okay. So this is mediastinum. Now important thing is cardiothoracic ratio. So what is cardiac thoracic ratio? So cardiac thoracic ratio need to see whenever we have to find out cardiomegaly. Okay. So as name suggests, cardiothoracic ratio. So cardiac diameter. So whenever there is maximum cardiac diameter, we have to take. So we can see this distance. This is cardiac, the cardiac diameter. Okay. Then cardiothoracic. Thorax means chest. Whenever there is chest, we have to take maximum diameter. This is this. This is thoracic diameter. Okay. So ratio of cardiac to thoracic or CT ratio, cardiothoracic ratio, it should be less than 0.5, less than 50%. If it is more than 50% or more than 0.5, it means there is cardiomegaly. Cardiomegaly, maybe because of CHF, maybe because of anything, but there's cardiomegaly if ratio is more than 0.5. This is cardiothoracic ratio. Now, next thing is bone and soft tissue. The bone and soft tissues, what are the bone we have to look for? Ribs. This is ribs. Ribs are anterior ribs and posterior ribs. In first lecture, I told you when you are taking PA view, PA view means radiation coming from back side and coming to anterior side, from posterior to anterior. So posterior ribs will come anteriorly, and anterior ribs will see in posterior side in chest X-ray. So this is PA view. Okay. So anteriorly, what ribs will we see? Anteriorly is posterior ribs. This is posterior rib. And whereas anterior ribs is posterior in the chest X-ray. So this is anterior ribs. See, count. This is one anterior ribs, two anterior ribs, three, four, five, six, seven, eight. This is anterior ribs. Posterior ribs is 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have to count anterior ribs and posterior ribs. So what the significance of ribs? You can see rib fracture, which is the most common in trauma, chest trauma, rib fracture you can see. Second thing is if there is a tumor inside the chest which can infiltrate bone. Osteomyelitis you can see in especially in tuberculosis. So, and rib counting is helpful for to see whether it is inspiratory film or expiratory film. If anti-ribs seen more than 5, then it is inspiratory film. If less than 5, it is expiratory film. So this is significance of ribs. Then intercostal space. The space between two ribs. So this is one rib, this is two ribs. The space between two ribs. If it is narrow, it means there is something which is collapsing the lungs, maybe fibrosis or collapse. So if there is collapse here, then this ribs will come closer. So this is intercostal space which will be narrowed in case of fibrosis or collapse. So both sides we have to compare between left and right. Where is the narrowing of intercostal space? Then coming to scapula. See, here it is scapula. So this is good inspiratory film and PA view. That's why scapula is not coming in lungs. Otherwise, in some X-ray, you can see scapula come like that here. Okay. So we can see scapula. Then clavicle. So where is the clavicle? I told you spinoclavicular junction. No. So this is clavicle. So what is the significance of clavicle? One is we can see if there is any fracture. In trauma, we can see fracture. Another thing is spinoclavicular distance to see rotation, as I discussed earlier. Then muscles. We have to see muscles. See muscles and fat means extra thoracic muscles, soft tissues we have to look for. So this is muscles and soft tissue. So if there is surgical emphysema or subcutaneous emphysema, we can see ear here. Here. So this is muscle and soft tissues. Now coming to lung parenchyma. This is the black area is lung parenchyma. So as I told you in last lecture, whenever there is air, it will give you black shadow. If there is liquid or vessels, it give you white things. Okay. So in lung parenchyma, there are two things. One is alveoli. one is alveoli, which is having gas and taking part in gas exchange. Another thing is the surrounding alveoli is blood vessels. See, you can see blood vessels. Okay, blood vessels, and there is connective tissue which is protecting alveoli and lungs. So alveoli, surrounding alveoli is blood vessels and connective tissues. Okay, so in lungs we can see two things. There is blackness because of alveoli. Okay, and this is white, you can see this is white things. So what are the things? These are the interstitium, means blood vessels and interstitium. Okay, so these two things we have to see. One more thing you have to remember: if there is normal X-ray and normal individual, the blood vessels we can see up to 2/3 of thorax. In lateral 1/3, we should not visualize blood vessels or interstitium. But if there is blood vessels in lateral third also, it means there is high vascularity. For example, congestive heart failure or volume overload. So if there is interstitial marking in lateral 1/3, it means there is problem, either interstitial lung disease or there is increased vascularity because of congestive heart failure or anything. If these white markings, if you see very prominent, it means there is septal thickening. You can think of interstitial lung disease. We will discuss later, no problem. Okay. Now coming to pleura. So my question is to you that can we see pleura in normal chest X-ray? The answer is no, because pleura has two layers, vessel pleura and petal pleura, and these two layers are very thin. In normal X-ray, we cannot see. We can see pleura only when it is get thickened, when there is calcification, or if there is pleural pathology like pleural effusion, pneumothorax, or pleural thickening, or empyema. Otherwise, normal X-ray, normal individual, we cannot see pleura. Okay, I think I'm clear. Now, question for you: is it normal X-ray? You will say no. Why? Because you can see here more black as compared to this area. So right side more white, left side black. So this is not normal. Okay, but this X-ray is normal, because when you are seeing X-ray, you have to see breast shadow, especially in female. Okay, in right side you can see this breast shadow. Okay, breast shadow is soft tissues, so it give whitish appearance. But left side there is no breast. Here no breast. So this is case of mastectomy. Her left breast has been removed surgically. So this X-ray is normal, but we have to look for breast shadow in every patient which is female. Okay. So how to see breast shadow? So breast shadow, it will extend up to outside the thorax. See, it starts from lungs, it will go up to outside of thorax. So this opacity continue up to outside of thorax. So this is breast shadow. So this is normal X-ray. Now coming to lateral X-ray. So lateral X-ray, though we are not getting it frequently, but we should know basic things to see in lateral X-ray. So if you combine PA view and lateral X-ray, then you can see, you can have a 3D view of a opacity. So if you want to see 3D look, then you have to combine both PA view and lateral view. So lateral view, few things need to be seen. What are the things? First, we have to see CP angle. So whenever there is minimal pleural effusion, which is not obvious in PA view, you can find that effusion in lateral X. So it will be oblated in minimal pleural effusion. Second thing is you can see vertebrae. Okay. Another thing is you can see heart border. See, this is heart border. So heart is anterior and vertebrae is posterior. Okay. Heart border, what are the things we need to see? Heart border, as I told you, right ventricle is anterior. That's why we cannot see in PA view, but you can see here, right ventricle. Here, left ventricle. And posterior side, left ventricle and right atrium. The left atrium. Okay. And this is ascending aorta, arch of aorta, and descending aorta. Can you see here? This is arch of aorta, this is descending aorta. Okay. Another things we have to look for, diaphragm. So these are diaphragm. Since it is lateral X-ray, so both diaphragm we can see this is overlapping. The diaphragm which is superior side, that is right diaphragm, and lower side is left diaphragm. Okay. So these are the things we should see in lateral X-ray. One more thing is you can see two black area here. One, two. So anteriorly is trachea. So this is trachea. And behind that is esophagus. So this is trachea, this is esophagus. Because esophagus is posterior to trachea. So first you can see trachea anteriorly, then posteriorly is esophagus. So this is lateral X-ray. So if there is any opacity behind the heart here, we cannot see in PA view. For that, we can see in lateral X-ray. If there is opacity in retrosternal area, we cannot see in PA view, but we can see in lateral X-ray. So lateral X-ray will give you 3D idea of any opacity. So if you combine PA view and lateral X-ray, you can see all things. Okay. So this was practical how to read a chest X-ray. Now, for exam purpose, you have to read X-ray like that. First, you have to check name, whether PA view or AP view, rotation, spatifilm, exposure. These are the technical things. So you have to see technical things first, then you have to come for findings. For findings, you have to go in this manner only. We have to look for bone and soft tissues, mediastinum, diaphragm, and then last lung parenchyma. So you have to tell in this order only to examiner, then only examiner will give you marks. Okay. For example, this is normal X-ray. So whenever examiner give you chest X-ray and ask, kindly read it. So how will you read a chest X-ray? What mistake we are doing in exam? We are just jumping to opacity which is there in lung parenchyma. See, there is mass in the right middle zone. No. We have to read X-ray carefully and systematic manner. How? Sir, this is chest X-ray view of Mr. XYZ. There is no significant rotation. This is inspiratory film and exposure is adequate. Okay. Then findings. Bone and soft tissue are normal. Mediastinum centrally placed and seems to be normal. Diaphragm are normally placed. Lung parenchyma seems to be normal. So this is how we should read normal X-ray in your exam. Okay. Now, lung parenchyma. So before reading a abnormal X-ray, we have to see which lobe is involved in our chest X-ray. How to see? First, we have to learn surface anatomy. So right lung has three lobes: upper lobe, middle lobe, lower lobe. Left lung has two lobes: upper lobe and lower lobe. In upper lobe, we can have subdivision like a lingula. In right side, there are two fissure: oblique fissure, also called major fissure, and horizontal fissure, also called minor fissure. Left side, only oblique fissure or major fissure. Okay. So if you know the surface anatomy of this fissure, you can tell which lobe is getting involved. How to see? So this is famous diagram from Algappan book, and you can see posterior, you can draw a point, that is T2. If you palpate yourself, then you can find one bony prominence over the vertebral column, that is the T2. Ask patient to raise their hands. Then you draw a line just below scapula and come anteriorly and join 6 costochondral junction. So this is major fissure. Another point, you take from fourth costochondral junction and join major fissure in the line of axilla. In axilla, you join major fissure. This is minor fissure. So this is major fissure and this is minor fissure. Okay. In X-ray, you can see here is T2 or here is major fissure, this one, and this is minor fissure. Okay. So major fissure divide lung into upper lobe and lower lobe. And minor fissure divide upper lobe into upper lobe and middle lobe. In left side, major fissure divides lungs into upper lobe and lower lobe. Okay, so if you see carefully, anteriorly, this is anterior. Anteriorly, majority of portion is occupied by upper lobe. Okay, below little one is middle lobe. So middle lobe, where it is lies between minor fissure and major fissure. Okay, in anterior side, very little part is occupied by lower lobe. So whenever you are examining anterior chest wall, like you are doing percussion, auscultation, anything, it means you are examining upper lobe and middle lobe. If you are examining posterior side, then you are examining lower lobe. See, this is lower lobe. Okay, so lower lobe is occupied posteriorly, anteriorly, upper lobe, and middle lobe. Okay, so in lateral X-ray, major fissure is T2 to just a few centimeter from diaphragm. So this is major fissure. Okay, so anterior to major fissure is upper lobe. Okay, posterior to major fissure is lower lobe. So lower lobe occupies posterior area and upper lobe is occupied by anterior. Right side, there is minor fissure. Here is minor fissure. So the area between major fissure and minor fissure is upper lobe. Area between minor fissure and major fissure is middle lobe. And the posterior from major fissure is lower lobe. So this is how we can divide lungs into lobes. Okay. And one thing you can notice, this area, this is having heart. So heart, the area which is occupying with lobe is middle lobe. So whenever the involvement of heart, you can label it as middle lobe. Okay. So anteriorly upper lobe and middle lobe. Posteriorly is lower lobe. Extreme upper, you can find this is upper lobe. But majority part is lower lobe. I think I'm clear. Okay. If you see in X-ray PA view, the upper area is upper lobe. Okay. But you cannot say definitely because this is 2D structure. Then we have to get lateral X-ray done. So lateral X-ray, see, this is major fissure. This is minor fissure. Okay. So this is upper lobe. See, minor fissure, major fissure. So this area is upper lobe. Okay. Then opacity in lower side. In 2D structure, we cannot say whether it is lower lobe or middle lobe. So we have to get lateral X-ray. Lateral X-ray, this is middle lobe, this is minor fissure. This is middle lobe. See, this is middle lobe. So minor fissure and major fissure. The area between minor and major is middle lobe. This is middle lobe. Right lower lobe. You can see area in lower part of chest X-ray. Okay. So one thing you should understand that usually lower lobe mass or consolidation opacity touch diaphragm. So any opacity which is touching diaphragm, it means there is involvement of lower lobe. For confirmation, you have to get lateral X-ray. Okay. So lateral X-ray, this is T2, this is major fissure. The area behind major fissure is upper lobe. So this is right upper lobe. Okay, this is right upper lobe. Sorry, right lower lobe. My mistake. Right lower lobe. Okay. So area behind major fissure is lower lobe. Okay. Now this is. So this is left lobe, left upper lobe or lower lobe. We have to get lateral X-ray. Lateral X-ray, can you see this is behind major fissure. So this is left lower lobe. So this is major fissure and area behind that is lower lobe. Okay. And this is upper side. But for confirmation, we have to get lateral X-ray done. So this is major fissure. Okay. So area anterior to major fissure is upper lobe. Okay. In this X-ray, we can see upper lobe. This area just anterior to major fissure is upper lobe. This is left upper lobe. So question for you, what lobe is involved in these X-ray? So in first X-ray, you can see there is opacity and you can see this is minor fissure. Can you see this is minor fissure? This is minor, very sharp. So opacity above minor fissure is upper lobe. Between minor fissure and major fissure is middle lobe. And below major fissure is lower lobe. Clear? So this is upper lobe above minor fissure. This opacity. If there is obscuration of diaphragm or diaphragm is not clearly seen, it means lower lobe. If any opacity which is orbitating right heart border is middle lobe. So this is right lower lobe. And this opacity, you can see this is obscuring heart border. Okay. If you get lateral X-ray done, we will confirm it. Okay. So lateral X-ray, if opacity between minor fissure and major fissure, it is right middle lobe. Okay. So in lobes, regarding lobes and segment, I have made detailed video. Okay. So you can check my YouTube channel. So you can find X-ray as well as CT scan. Okay. So for better understanding, please subscribe my channel and see my previous video. So this is enough for this lecture. We will see with next video. So thank you very much.